Roll call. Melina Kraft.
Present.
Jill Johnson.
Here.
All right, Emily Cody.
Here.
And Joey Cantz. Present. What a chip is?
You mean like these chips, Mr. H?
No, Joey.
Well, actually, it is an insurance program for low-income children.
Oh, very good, Melina. Chips are for winners.
Hey.
Hey guys, now we're going to go around the class, and everyone's going to say one thing you think we need to know about chip.
Ooh, like the flavor?
How about history, Joe?
How about the political, economic, and social factors?
Oh, good. I like that one.
Give me my chips, Joe.
How about how to work it?
Okay.
And the good and the bad.
Okay, good. Well, let's watch the prezi you guys made about this now.
First, we need to understand the past in order to get an understanding of how far children's health has come and which area needs to be improved upon. As one can imagine, from the time European travelers settled in the Americas until about the late 1800s, there was a very high child mortality rate. And specifically, the highest rates were among African Americans and what was called then Indians, but what we refer to now as Native Americans. Not much of a difference between mortality rates for the rich or poor. An example would be Cotton Mather, who was famous during the Salem witch trials, renowned for his scientific work regarding disease prevention. But he was pretty wealthy. He had 15 children, and only 2 of them made it past 12 years old and into adulthood. During the late 1800s, there was much more public awareness of how poorly children's health was, which led to different innovations such as the Safe Milk Campaign, where people started to pasteurize milk and dispense free milk in some major cities. Also in the 1880s, other campaigns encouraged doctors to put silver nitrate in newborns' eyes to prevent blindness. And also there was a law passed in New York City which mandated vaccinations for children to prevent smallpox. The late 19th, early 20th century showed even more improvements in public health in general, which improved sanitation techniques and cleaner water supply, which in turn helped out children as well. There were also successive campaigns to find ways to prevent catastrophic childhood diseases like whooping cough, chorea, yellow fever, and polio, and it helped bring the threat of childhood diseases under control. So now we're going to look at the early 20th century, and as we know, the government took a much more active role into the healthcare industry during this time. In 1912, the Children's Bureau Agency was established, but the agency's call for universal health care for children was never really realized, as support for public contributions to a healthcare system for children never really developed. In 1929, a Michigan senator allotted $10 million to establish the Children's Fund, though there was an unusual requirement that all the money must be spent within 25 years. But within those 25 years, it financed maternal and infant health clinics throughout the Depression. The fund also supported basic research in children's nutrition and gave money for school lunch programs. The infant mortality rates in Michigan declined during the Depression, we think because of this. The Social Security Act of 1935 brought great changes as well to the health care and children's health care, bringing with it different World War II programs which helped support soldiers' infant children while they were away at war, and also a national school lunch program was developed as well to ensure children were getting the proper nutrition they needed every day while at school. And lastly, in 1965, Medicaid was enacted, which eventually paved way to a much more organized children's health insurance that we know today. The Children's Health Insurance Program, abbreviated CHIP, C-H-I-P, it was established in 1997, and it is a joint federal-state program, which means that the government provides federal matching funds to states to provide health coverage to children and families with incomes too high to qualify for Medicaid, yet too low and can't afford private coverage themselves. As I touched on earlier, CHIP was built on the underlying Medicaid program, and at the very minimum, it requires medical coverage for children up to age 6 with a family income less than 138% of the federal poverty limit, and up to age 18 with a family income at or below 100% of the federal poverty limit. Coverage does vary from state to state, as those figures I just mentioned were the basic minimum requirements.
Although the goal of CHIP was to increase the number of uninsured children in low-income families, there were still mixed feelings toward it. For those who opposed its ideas, such as Heritage Foundation, they believed it inadvertently covered too many middle-class children and was a way for for-profit companies to seek tax breaks for providing the insurance. On the other side, for those who were for it, they saw it as a way to find balance between the state and federal government, while also providing a balanced set of ideas from the Republicans and Democrats alike. It guaranteed certain benefits to a part of a population which are elements of an entitlement program, as well as incorporating aspects of a block grant being where the national government gives provisions towards spending to the regional government.
There were many economic factors that helped contribute to the creation of CHIP. For the U.S. economy, healthcare expenditures were on the rise, and one major factor that contributed to these rising expenses was the large uninsured population. For example, those who were uninsured were more likely to seek care at emergency departments due to state and federal regulations requiring that hospitals turn no one away without an appropriate assessment. These visits are at a higher cost than care provided at a physician's office or other ambulatory settings. Because of this, there is a desperate need to expand health insurance and find a way to make it affordable and accessible for the uninsured population, especially the population of low-income children. Through the expansion of health insurance, low-income children may go see a primary care physician instead of making a trip to the ER, which would also be beneficial for the U.S. economy in hopes of decreasing healthcare expenditures. On the political side, there were attempts made to make insurance more accessible and affordable. In order to expand coverage, states were given 3 choices. These choices included expanding their Medicaid programs, funding private insurance programs, creating new state health care programs, or some combination of those 3. States could also apply for a waiver from the federal government to cover people other than children aged 18 and younger and families who exceeded the income limit. By doing this, it forced each state to find a way to expand their coverage to other age groups. Another attempt was made in the 1990s when the Clinton administration attempted to push for universal health coverage but failed due to denial from Congress. Throughout history, there were many attempts to reauthorize the Children's Health Insurance Program in order to help increase federal funding and expand coverage. Between the combination of successful Medicaid expansions in the 1980s and the failure of the Clinton health reform proposals of the 1990s, set the stage for both Democrats and Republicans to cooperate and come together in finding a way to expand health insurance for 10.1 million uninsured low-income children. All these attempts paved the way for the improvement of the Children's Health Insurance Program.
Okay, guys, what do you think of the Prezi so far?
I still don't get it.
Well, it's okay. There's still more to learn, and we'll figure it out as time goes on.
Where's Joe?
Joe's 19.
That means he doesn't qualify anymore.
Wow, very good. More chips.
Yay!
Now we are going to talk about the navigation of the CHIP system. Because each state has a different program with different rules and services provided, navigation can get very, very tricky. Today we are just going to look at the Missouri and Illinois programs. The Missouri program is called Mo Health Net for Kids, or MHK. Currently, families in 54 counties across the state are covered by this program. The Mo Health Net program is also in charge of other Medicaid-funded programs, but we are just looking at CHIP today. As you can see from the screenshot taken directly from the Missouri Department of Social Services, the page that explains the benefits of the program covers many different groups, including families and pregnant women. This makes it a little confusing to figure out what will be covered and what will not be. From what we found, it is very difficult to acquire information about premiums and copays in the Missouri plan unless one actually applies to get the coverage, which can make deciding on joining the program more difficult. The Missouri plan does give information about what kind of coverage will be given. Most participants are on an MCO or managed care organization. However, if they desire, they can choose a fee-for-service plan, which gives them a little bit more freedom with what doctors they would like to see. Okay, now moving on to the Illinois plan, which is called All Kids. The website for this program is much more user-friendly and easier to understand. As you can see from the screenshot, once again taken straight from the website, experts have already answered many questions that a prospective participant might have, such as questions about immigration status and continuing coverage. It discusses all the requirements of being in the program without having to dig through the whole site. On the second part of this webpage, you can find even more questions and answers that apply to real-world problems. I learned a lot about this program from just this one page. For example, children who meet income requirements will be eligible for All Kids, regardless of immigration status. This webpage also gives specific monetary amounts one must make to be eligible for coverage, which makes deciding whether or not you can apply much easier. Additionally, all copays and premiums are laid out very simply on this chart, from hospitals to prescription drug coverage. One problem that we saw in both programs is that on the web pages both combined information with information from other programs, which can lead to mixing information up. And overall, we can't say which program is better. But what we found is that the Illinois program was easier to navigate online if one is not ready to commit to the program just yet.
One of the greatest strengths of the Child Health Insurance Program is that it guarantees children to have a comprehensive benefits package. This not only includes the basic mandatory health care, but rehabilitation services as well. This is known as early and periodic screening, diagnosis, and treatment, which enables the children to obtain, maintain, and even improve their overall well-being and health. This leads to a healthier, younger generation. All CHIP programs include dental care. Dental disease is considered the most common childhood disease, even though it can be prevented with proper care. Programs also include eye exams, coverage for glasses, hearing exams, mental health services, both inpatient and outpatient, substance abuse treatment, physical therapy, speech therapy, and occupational therapy. Another strong suit is the fact that out-of-pocket family costs, including premiums, can only be 5% of the total income of the family. Moving on to weaknesses, children enrolled in CHIP visit the emergency room department more often than uninsured or privately insured children, 13% higher than the uninsured and 3% higher than the privately insured. This could be blamed due to the barriers of access to the child's primary care physician and lack of evening hours. Children covered under CHIP also experience extreme difficulty getting into a specialty physician. This is caused by the fact that Medicaid patients cost more to the physician than privately insured. Therefore, they are reluctant to refer these patients to their colleagues. Another downfall to the program is the fact that families can lose coverage very quickly. Before the ACA, receiving a raise, working a few hours overtime, getting pregnant, or having a child turn 19 could all influence if the family receives coverage for the child or children or not. The paperwork to ensure that these aspects of life are documented is also very daunting. The ACA managed to revamp this system to ensure that children would receive the health care they needed for the full 12 months. This lessened the amount of paperwork and gave parents ease of mind knowing that their child were covered for that year.
Okay guys, before we end class, does anybody have anything they'd like to add?
Thanks for watching our presentation.
And thank you to the Scottish Walker Wright Clinic for letting us use their facilities.
And thanks for the goldfish. Snack the smiles back.